I was honored by ASCO this year to provide the beginning of the breast cancer session and an overview on what many of us believe is the major subject in hormone receptor positive breast cancer, and that's the issue of late recurrences. To provide a little bit of background, this is the most prevalent subtype of breast cancer, and overall our treatment results have become really excellent. So we are discussing cure rates of 80% and more in this setting. However, other than with many other cancers, it's not in a situation that after you have successfully undergone surgery, radiotherapy, and initial treatment, and then in the early years there is some risk of recurrence, and like in gastric cancer, after 5 years, you can consider yourself cured, more or less. Cure is a word that we use only very humbly in oncology. But in luminal breast cancer, the pattern of recurrence is different. So it's very low in the beginning, but it keeps existing at a low state for a very long time. And that obviously poses a challenge, because when that risk persists for a long time, and long time, when I say long time, I mean it's 15, 20, 25 years even after the initial diagnosis, at a very low rate, maybe 0.5%, but 0.5% over 20 years is also 10% of all patients. So we are trying to do something about that. And one thing that has been tried in the last 2 decades is extending the duration of endocrine treatment. Quite logically, if the risk persists, why wouldn't we also extend the treatment duration? I mean, nobody in other fields of medicine, if you suffer from hypertension, nobody would give you antihypertensive drugs just for 2 years and then stop. So you will get your treatment as long as the threat exists. And the same has been tried in breast cancer, but there is some natural limitations to that. Number one is that all our treatments have some kinds of side effects, at least in some patients, and you cannot give them forever. There is an obvious economic limitation to that. You cannot treat such prevalent disease everybody forever. And I gave a little bit of an overview of what these trials have resulted in, and that message is that yes, unless you are at very low risk, then you benefit from extending the treatment duration beyond the usual 5 years, which is considered the standard treatment. However, extending to 10 years is not necessary for the majority of patients, so the optimal results are achieved for the majority of patients with a treatment duration of 7 to 8 years. And that's also important because these treatments also have side effects that are not only annoying, but some of them even dangerous, particularly the issue of bone health, for example. So there is a natural limitation what you can do. And if you extend the treatment, for example, as we have shown in a large ABCSG 16 trial that has been published in the New England Journal of Medicine, you do not benefit from an extension from 7 to 10, but you will increase your fracture rate, and obviously that's something that should be avoided. So for the majority of patients, 7 to 8 years is good enough, and 10 years is reserved for patients at really very high risk. So like with 5, 6, 10 positive lymph nodes. And that became reasonably clear in the recent years, and also the most recent St. Gallen consensus conference has defined that risk basically defines the duration of endocrine treatment. On a positive note, we have demonstrated that in luminal breast cancer, an observation exists that we call the carryover effect. So what does that mean? It means that we can, even with limited treatment durations in the beginning of the patient journey, provide benefit, and that benefit is long-lasting. It's not going away once we stop the treatment, but you know that we usually depict this in survival curves, and usually a benefit we achieve persists there, and these curves are not coming together again at later follow-up. It's an interesting observation. It's a reassuring observation because obviously we are able to change something in the course of the disease. Theories around that is affecting the nesting of dormant tumor cells, which are believed to be the source of late recurrence. And when we can hinder them in going to a, let's say, comfortable dormancy or put them to what is called senescence, then they might not be able to wake up again, to remain within that image, and that's very reassuring, and it has been demonstrated for quite a number of historic treatments, but also contemporary treatments. And since we are seeing in particularly in hormone receptor positive breast cancer such an explosion of new innovation with CDK4/6 inhibitors, with a completely new class of drugs, the oral selective estrogen receptor downregulators, SERT abbreviated. But even beyond that, we are seeing early results from clinical research about drugs that are called serans or PROTACs. So these are all arriving in clinical trials as we speak, more or less. And I think one can be very optimistic that if any additional benefits for patients we can define in the years to come in the early setting will also, via the carryover effect, persist long-term and benefit our patients for a very long time, which obviously would be a very reassuring finding.